Good morning, everyone, and welcome to the second day of the live sessions at NTW22. This morning promises even more learning and sharing. And to join in, which we really want you to do, please just use the Q&A button either at the top or bottom of your screen, and the panel will try to answer as many questions as possible. National Thrombosis Week virtual conference would not be possible without the support of outstanding medical leads, such as those here today, who give their time to present and develop each session for you freely and willingly. The collaboration from professional bodies and sponsorship from organisations, either in the form of an exhibition stand or sponsored symposium. Please do visit the exhibition area. There are stands there packed with information from professional bodies as well as sponsoring companies. So, waiting to begin, we have a panel of incredible VT champions who are about to share, discuss and answer your questions. I hope you have brought plenty of them. Chair for today is Emma. Emma G is a nurse consultant in thrombosis and coagulation. She joined King's thrombosis team in 2007 as a coagulation clinical nurse specialist, rotating through DVT, anticoagulation and VT prevention roles. In 2014, she became the nurse consultant in thrombosis and coagulation, with responsibility for the nursing thrombosis teams across the King's College Hospital sites. And shortly after this, Emma became the lead for the VT National Nursing and Midwifery Network. And sometimes I'm not sure where I'd be without Emma's help and support. So over to you, Emma. Thank you very much.
Very kind introduction. Thanks so much, Jo. And welcome everybody. Very warm welcome this morning. It's a pleasure to be here. And thank you so much to Thrombosis UK for inviting us to this session this morning. And of course, to their wonderful CEO, Jo Jerome, for putting this wonderful virtual conference together. And today we are talking about quality improvement projects to improve emissions of low molecular weight heparin. Now, if you have read the VTE GIRFT study survey report, you will have seen that of the 14 recommendations, number 5 was focused on suggesting that hospitals should develop quality improvement projects targeting missed low molecular weight heparin doses, because they found that in the survey 8.1% of doses were missed, and that percentage rose to 20% when looking at cases of hospital associated VTE. And we know that thromboprophylaxis is only about 60% effective at best. And so we want to make sure that we give patients the best chance, and we want to make sure that they get all of the doses that they are prescribed where it's appropriate to do so. And in doing that, we stand a much better chance of reducing the risk of hospital-associated thrombosis. It's well worth having a look at the report on the Thrombosis UK website if you haven't already. It contains lots of other information and recommendations just to help you build your strategy. First of all, though, I'd like to introduce our first speakers. So we've got some excellent members of the National Nursing and Midwifery Network for VTE, who are going to talk to you today about quality improvement projects that they've undertaken locally in their trusts, to give you a bit of food for thought and some ideas about how you could do this yourself. Now, I think the timing is good because hopefully we're all kind of emerging from our COVID bubble that we've been in for the last couple of years. And now our focus is really turning to what's next. What can we do next to improve care for our patients and improve patient safety? So hopefully this will give you some insight into how you might do that. And the floor is yours. As Jo has said, please use the Q&A button to submit questions while the speakers are talking, and we can get to those questions afterwards. And no question is a silly question, please ask away. So first of all, I'd like to introduce my colleagues. Becky Simpson is the lead nurse for VT prevention at Ashford and St Peters in Chertsey, and she's a member of the VTE National Network for Midwives and Nurses. Becky joined Ashford and St Peters Hospital in 2013 and established the VTE Prevention Service, which very quickly, just 3 years later, achieved VTE Exemplar Centre status. Fantastic achievement. She continues to oversee the VT prevention programme, which has been nationally commended, and she's currently working with a newly established multidisciplinary harm-free care team. Also joining us today is Ria Wright. And Ria is Clinical Programmes Manager in the quality improvement team at Ashford and St Peters. And since moving away from the clinical environment in 2002, Ria has undertaken a variety of service, general and project management roles across acute and strategic healthcare settings. Over the last 10 years, she's worked as a clinical program manager using the Institute for Healthcare Improvement Model for Improvement methodology to reduce patient harm in many areas across the trust, including most recently medication safety. So a very warm welcome, Becky and Ria. I'd like to hand over to you for your presentation.
Thanks, Emma.
Thank you.
Lovely warm welcome. Thanks, Jo. So as Emma said, my name's Becky. I'm just going to start off our presentation and give you a little bit of a background as to how we started our QI project, and then I'm going to hand over to my colleague Ria, who's going to give you the kind of meat and bones of what we did. So I can have the next slide, please, Jo. So really what I'm going to talk about is what prompted our QI work at Ashford and St Peters. And our initial drivers, unfortunately, came from a coroner's case that came about in 2016-2017. And we had a gentleman who had a prolonged admission period with us. He actually was medically fit for discharge within 24 hours, but was waiting for a social care placement and ended up being with us for 74 days. And unfortunately, during that time, he had a fall and he had a fractured ecophyma, which had to be surgically repaired. Now, during the time he was with us, he was appropriately risk assessed for his level of thrombotic risk and level of bleeding risk. And he had the appropriate preventative measures, so chemical prophylaxis and mechanical prophylaxis prescribed and put in place for him. But during the course of that admission, two major things happened. We had a period of multiple unexplained omissions of his prophylactic low molecular weight heparin. And what I mean by unexplained omissions is that we either had blank spaces on the medication administration charts. We're just moving over to electronic at the moment, but we're currently still paper-based. So we had blank spaces. So you have to take that as an unexplained omission. And we also had omission codes. But the omission codes that were put in to the boxes were things like code 4, which for us just means other. So we couldn't explain why those doses were omitted. We went through their medical notes and discussed the case with everybody involved, and nobody could remember why those doses were not administered. So we had lots of unexplained omissions. And also throughout the course of that admission, there was an incorrect creatinine clearance, either documented or calculated onto the patient's drug chart, which resulted in an incorrect renal dose adjustment. So the patient received suboptimal prophylaxis also for an extended period of time during that 70+ day admission period. So that was one of our first kind of real drivers where we looked at this case and we were like, we need to make sure that we have things in place to make sure that this doesn't happen to anybody else in our care. And one of the other drivers that we were looking at the time was our trend data when we were reviewing our cases of HAT. And as you can see up on the slide there, sorry, it's formatted a bit unusually there. So for 2016 and 2017, all of the cases that were potentially preventable, so all of the cases of HAT that were potentially preventable were due to having multiple omitted doses of low molecular weight heparin, and the same again for 2017-2018. Now I'm going to leave the data there because I'm going to talk about the trend data when we get to the end of the presentation after we've discussed what we did based on these initial drivers. And then obviously, as Emma was saying earlier in the introduction, we then had the GIRFT, which has come along as another really powerful driver for this quality improvement work. So I'll hand over to my colleague Ria. So we were very, very lucky at Ashford St Peters that we've got an amazing quality improvement and programme management team who were able to help us develop this and drive the programme. So I'll hand over to you, Ria.
Thank you, Becky. Thanks for bigging me up as well.
Oh, you're amazing.
I'm just going to, oh, actually, Jo, can you just go to the next slide, please? Thank you. So I'm going to do a real whistle-stop tour of our medication safety programme, and we'll hone it in specifically on the VTE omission work. But I'll also going to very briefly explain some of the quality improvement methodology that underpins it. So when you're doing a change of any type, you need to know that the environment exists to support that change. And the first thing you look at is what's driving it. And I think Becky's explained very well what drove our change at Ashford St Peters. But normally it's because people are not happy with the status quo, that they know they have to change something. But it could be change that is national. So I guess the GIRF report is a national driver. The second thing that you'd look at is the buy-in that exists in the area that you want to make the change. So we had executive level buy-in, and we approached it from a trust-wide perspective. But this can be scaled right down. It can be scaled down to divisional level or ward level. But as long as you've got the engagement from some key people with influence in that area, so people like your ward managers or your pharmacists. And the third one is an improvement methodology. And I urge you really not to wing this one, because you will make it hard for yourself. So we use the Institute for Healthcare Improvement, their methodology, and they have something called the Model for Improvement. And it is so simple. There are 3 questions. Joe, could I have the next slide, please? Thank you. So the 3 questions you ask at the start is, what do you want to improve? And then what measures are you going to use so that you know the changes that you've made have actually led to an improvement? And then the last question is, what changes are you going to try? So if we apply that to Ashford and St Peters, so what's the problem? Well, we were causing medication-related patient harm. How were we going to measure? Well, you need to keep this easy. So use something that you already have in existence. So we have a Datex incident reporting system. So we literally just decided that our measure would be the number of incidents of harm per month. We also set ourselves an aim so that we all knew that we were striving for the same goal. And we aligned our aim with the WHO global objective. They had a medication without harm objective where they were looking to reduce incidents of harm caused by medication by 50% in 5 years. And then the last question, what changes were we going to make? Well, we'd made hundreds, because this program wasn't just about VTE medication omission. It was all areas of medication harm. So we also looked at our high-risk meds such as insulin, antibiotics, opioids, and we had a whole big work stream around learning from incidents. Next slide, please, Joe. So the first phase is a sort of a diagnostic phase where you sort of want to gather your baseline data. So we looked at all the Datex incidents of harm in 2017, and we cut them every which way you can. We looked at type of incidents, type of medication, the degree of harm, the ward or the department area where they'd been reported. And this is just one of those data cuts, which shows these are incidents of moderate to severe harm. So that's your 3, 4s and 5s. And it was by type of medication. And I think you can see there that the top one is glaringly obvious. That's our driver. So we gathered this very objective data, and then to go hand in hand, we wanted some subjective data. So we ran a series of workshops with key members of staff. So our matrons, ward managers, staff nurses, junior doctors, pharmacists, specialist nurses, anybody really that was involved in the process of prescribing or administering medication. We didn't involve patients at this point, but we did involve them further down the line when we did some specific work around particular medications. So we got everybody in a room and we asked them the question, what keeps you awake at night in relation to medication safety? And when you finish a busy shift and you go home, what are those near misses that happen today that are your catastrophic harms of tomorrow? So when we had those answers and we married that up with this objective data, that gave us a priority of list of issues that we wanted to tackle. And if you go to the next slide, please, Joe. So we put together this driver diagram, and a driver diagram is an absolutely brilliant visual tool that we use in quality improvement all the time. And it helps organize all your ideas, and you discover various causes that contribute to the issue that you're trying to improve. So if you see there on the very left-hand side, we've got our aim, which is to reduce our harm by 50%. And then you have primary and secondary drivers, and they all help to achieve your final goal. In the right-hand column is all your change ideas that you're going to try. And as you can see, I've highlighted our omitted doses work stream. So you just see where that fits in the bigger scheme of things. And on the right of that is the change ideas that we were initially going to try to reduce our emissions. And the change ideas are a movable feast. So you change something, you test it to see whether it's had any benefit with your data, and you can either reject it, you can adopt it, or you can amend it. So if we just look at the reducing emissions now, that's the next slide, please, Joe. So the scale of the problem, a spot audit showed over a 2-week period that about a third of our patients had an omission. And the problems identified were that how and where the drugs were stored, there were interruptions in the drug rounds, the drugs weren't in a logical order in our drug charts, there was no process that was followed if a staff member found that a drug was unavailable. We had a particular problem with drugs not being given in the first 24 hours when a patient went from ED to the ward. So when you look at solutions, in quality improvement, small really is beautiful. You want to start really small and test your changes in a small area. And then if they work, roll them out. We never go big bang approach in QI. So we chose 4 pilot wards, which were a mixture of medicine, assessment and orthopedic. We asked those 3 little questions again. What is the problem? Well, we had too many omissions. How are we going to measure the problem? Well, we decided that we would just do a 2-weekly audit. We would randomly select in each ward 10 drug charts, and we would literally just count the number of blanks. We captured the VTE emissions separately, just so we'd have a gauge of those, because we knew that obviously they were the ones that were causing the harms. So we counted the blanks, and we also counted, as Becky described, if somebody had a code 4, 6 or 8. So code 4 is actually unavailable, and that's our real problem, that you have days and days of code 4 written in the drug chart, that the drug just isn't available. And I think there was very much a culture of, I'm just going to copy what was in the chart previously and not go and look for it. And then I think 6 and 8 is doctor and nursing decision. And if there was no further information on the back of the drug chart as to why that code was in there, we counted that as an omission. And we very much went by the mantra that the drug chart has to be the go-to document for anything medication related, and that you shouldn't have to cross-check with the medical or the nursing notes. And then the third question we asked ourselves is, what are we going to change? Well, we decided to do lots of small tests of change. And if you go to the next slide, please, Joe. So this is with, you remember, our 4 wards. So we generally raised awareness by, we put the run charts up that we collected. When we collected the data, we made sure that the run charts were up on the wards patient safety boards. Because it's very powerful just seeing the data on a 2-weekly basis, and that actually leads to change just on its own, almost by stealth, because it's at the forefront of everybody's minds. And we talked to the staff about the importance of not omitting a drug, because often I think they omit a drug and they never see the consequence of it. The consequence of that omission is when the patient has been discharged further down the line. And Becky and her team went to the wards to run some very powerful sessions around the case studies of the omissions of the VTE meds. And then we tackled the drug unavailable issue. So we had the pharmacy order sheet, we attached that to the drug trolley. We did flow diagrams just on a very simple process to follow if the drug wasn't available. We highlighted to the team the need to distribute the drugs once they've been delivered from pharmacy and not to leave them just in the box in the drug room. And we did a spring clean of all the drug rooms and the drug cupboards as well, so everything was in a logical order. We did another push on the red tabard, which is the if somebody was doing a drug round, they would wear the red tabard, which basically screams, don't interrupt me. And I can tell you now that doesn't work, because everybody goes up to the persons and says, I know that I'm not supposed to interrupt you, but. So that really just, and I don't even know whether they wear them now on the wards. We decided to really try and use our pharmacy techs, which they're a brilliant resource. So we had them trying to spot omissions as they were doing their pharmacy reconciliation. We also put a senior pharmacy tech working in ED, and she made sure that all the patients, when they left ED and went to the ward, that they had all the right drugs with them. But the intervention that made the most difference was very simple, and that was a drug chart check when the nursing shift handover took place at the bedside. And that was literally just running down all the drugs and looking for those blanks and then asking the nurse that was going off the shift, what happened here? And we trialed that on AMU, and it initially showed a dramatic improvement, and that improvement was sustained. And once we had about 6 audit cycles of sustained improvement, we rolled it out to our other 3 pilot wards, and then we rolled that out trust-wide. And you'd think easy, right? That's such an easy change, checking the drug chart, but it was very challenging. Once we'd done it on AMU and we'd shown it worked, it was challenged by other wards. They said that they didn't have time. A lot of the wards weren't at that point doing bedside handover. There was the issue of agency and bank staff that didn't know the process. But we used our ward manager from ANU to convince her peers that if she could make it work in a very busy medical assessment unit, then they could make it work in their ward. And we got the other wards trialing it just in one bay on one day, just to see how long it took and the difference it made. And we continued to audit, and eventually the data evidenced improvement across all 4 wards. And we had the support of our chief nurse, and now it's actually mandatory nursing practice. We plan to do a good practice handover video soon, and our chief nurse has volunteered to take part in that. So we're still auditing, it's work in progress. Our omissions have come down dramatically, but we've not eradicated them. We still have the issue of the dreaded 4s and the unavailables, and we're still tackling that. But if we have the next slide, I can show you what happened with our VTEs. So I don't know how much people know about run charts, but they tell a story over time. And if you can see, we started off back in the summer of 2018, and at each audit cycle, so that's 10 drug charts, 4 wards, so that's 40 charts. So we were having a medium of about 8 omissions per audit cycle, and you can see that gradually drops down. So the red line is the medium, and right at on the right hand side, we're now down to 1 omission per audit cycle. There are a few blips in there, but if you sort of think of this in the context of COVID and the pandemic, then for a couple of things happened, which people couldn't do bedside handovers because of IPC. So the omission check wasn't done all the time. Also, most of our patients that came in with COVID, very quickly, I think in the pandemic, we started to put them on twice a day Clexane as opposed to once a day. So you're doubling your chance of omitting a medication, but we sustained that improvement. And if we see the next slide, please, Joe. And this is surgery. So recently, so it's back in February last year, we introduced the omission check-in in surgery. And as you can see, that medium has come right down very quickly, right at the point they started checking the drug charts, from 7.5 per audit to 1 per audit. And finally, for me, the next slide, Joe, this just really want to very quickly talk about everything else we did in the medication safety programme, because all of this contributed to the reduction in omissions, as well as the reduction in the overall harm. So we did meet the WHO aim. In fact, we reduced our harm by 60% in that 5 years, and that 5-year period was up in March this year. So we introduced a new drug chart where the VTE meds were with the regular ones, so they didn't get missed. We had a larger section at the back of the drug chart for the to put the omissions and the omission codes. We did medication safety weeks, and each day we had a different theme. So we did videos, blogs, posters, and we had tea trolley training. So if you see here on the right hand side, there's a very embarrassed looking me. So this really pushed me out of my comfort zone, trundling around all the wards with this trolley packed high with goodies. But I made myself do it, and I made myself do it for 2 summers running because it worked. And we went there, we had goodies, we had tea and coffee vouchers for staff that we gave out if they came up and spoke to us about medication safety. We talked to them about all the omission work. We asked them that question again, what keeps you awake at night with regards to medication safety. We were very busy on social media. So I think in the middle here, this is a tweet. So this is us, my colleague and I, we're at one of Becky's VTE training days. So we attended that. We had our own little stall where we spoke to the staff about the omission work. We did a monthly infographic. Each month was a different theme. This one here, it's the yellow top left, was around the enoxaparin. We had bespoke training days for our junior doctors. And very last thing at the bottom, we had medication safety huddles that were weekly, face-to-face. They've now gone online since the pandemic. They're hugely successful, very well attended, an MDT attendance, very informal. And we just discuss all the incidents or not all the incidents, but we discuss any high harm incidents or themes that may have cropped up in the last couple of weeks in the trust. And we then share the learning from that trust-wide. We've had a lot of VTE omissions come to this particular forum, and it's a good place to keep it high up on everybody's agenda. So for us, I guess it's, it was a trust-wide program, and I guess a lot of places this is not possible, but you can scale it right down. You can do it by your division or your ward. You just really have to show that there's a problem by getting the baseline data, get a couple of interested parties in the room, and then just come up with a few ideas to test. And I think you need to be prepared to fail a few times, but don't get disheartened. Because I say, even just collecting the data and sharing that leads to the issue being in the forefront of people's mind, and you get improvement by stealth. So Becky, over to you.
Thanks, Ria. So this is just the last slide from me, really, and this is just a very simplistic representation of how the programme has affected our potentially preventable hat rates. So if you look at the chart on the left hand side there, that's the percentage of potentially preventable hats. So the percentage of all of the hats that we had within that year that were potentially preventable. So as you can see there, in 2017-2018 it was 11.3% of all of our hats were potentially preventable, and that was solely down to, if you look across to the right hand chart, and these are the themes around the causation of the potentially preventable hats. And if you have a look, the 2017-2018 data there is a nice sea of blue. So that was all due to omissions of chemical prophylaxis. And then if we move into 2018-2019, we had a dramatic reduction in the percentage of potentially preventable hats, down to 2.94%. And if we move over to the right hand side chart, we can see there that again we're demonstrating that dramatic reduction in the omissions of the chemical prophylaxis. So 3 of the 4 cases were due to omissions, and one of the cases there was due to either a lack of risk assessment and a lack of prescribing of chemical prophylaxis. And then if we move on to 2019-2020, we've got 3.6% were potentially preventable HATs. And looking at the causative factors there, 2 of them were down to omissions. 1 was due to an incorrect dosing, and that was based on weight-based dosing. And 1 was due to a lack of prescribing. And then if we move to our last full data set, because we haven't quite closed off the last financial year yet, so if we're looking at 2020-21, so we had 2.7% potentially preventable HATs, and the total causation for those cases was all due to incorrect dosing, and they were all due to weight-based dosing. And in all cases, it was patients who were above 100 kilograms who, for the first portion of their admission, were prescribed just a standard dose as opposed to the BD dosing we'd expect at that body weight. So the case was deemed potentially preventable. So I think the data there demonstrated that the things that we were testing and the things that we were trialing really have had an effect and sustained that across that number of years. And it's become kind of really, really embedded in our practice now, particularly obviously around VT prevention, but around medication safety as a whole. And obviously our next piece of work now is bedding in that weight-based dosing piece. I think that's everything from us, Ria, isn't it?
It is indeed, yes.
Yeah.
Thank you for listening.
Yeah, thanks for listening, everyone.
Becky and Ria, thank you so much. That was absolutely brilliant. Such a fantastic project, clearly highly successful. A few things stood out for me. I think, first of all, getting the involvement of your improvement team, your patient safety team, those people that, as Ria's demonstrated, know how to do things properly, and just giving us a little bit of insight, I think, into the structure and the process that you used is really, really helpful to make sure that you do things in a very logical way. And like you say, starting small, I think, is really, really useful. A couple of things that stood out to me, I think, initially you talked about making people aware of the consequences of the emissions, I think is really important. And you talked about the fact that it's quite easy, isn't it, just for nurses who are giving out medications, just continue and think, oh, well, yeah, I'll just use the same code as whatever came before, without stopping to think, now look, if I do omit that and that person does go on to get a VTE, what might the impact and the effects be of that? And of course, everyone's up against it. There's time pressure. Like you say, they're being interrupted while they're doing their drug rounds. But I think that raising that awareness is the first step. I think that the other thing that really stood out to me as well is that you endeavoured to understand the root causes of the emissions, which again, I think is vital, isn't it? But if we're going to try to change and improve practice, and it seems very much that checking the drug chart at handover was such a no-brainer. And I can remember when I was on the wards, getting to the drug round, finding that a drug hadn't been given, or not being certain about whether that drug was given, and then having that dilemma of, now do I phone that nurse? They're probably asleep now, it's the day shift, they were the night shift, they may well be asleep. The time that it takes trying to figure out what happened, asking the patient, do you remember getting an injection last night, or whatever drug it may be, actually I can see that doing a quick look at the drug chart during handover would save an awful lot of time and be a good safety practice. We've had a very good question in from somebody watching today who has said, do you foresee any issues with reviewing the medication chart at handover when you move to an electronic medication chart? Which is a great question.
It is a really good question. Yes, I think would be the answer here. I don't know if you agree.
Yes, I mean, we were hoping that it would be our silver bullet answer solution, and that it would highlight that, sort of buzzers would go off and the skies would turn black and there'd be gnashing of teeth, if there was an omission. But we're not sure it's going to be quite as functional as that. So we don't know in practice how that's going to affect the drug chart check. But what it hopefully will make easier is audit. We're hoping that we should be able to audit at any one time, the whole day. We should be able to just pull off every single omission that's happened in the trust. And as I've said before, you know, that if you know the data, that is so powerful. Then if you just share that, that will lead to improvement on its own. Not all the time, but it does lead to improvement.
Yeah.
But we hold the huddles, the medication safety huddles, and we're all prepped to go. I think our go live date with our Cerner is in 8 days.
Right.
So our next medication safety huddle, we are going to probably keep for all the issues that have arisen since we've gone over to e-prescribing.
Yeah.
It's going to be 8 hours long.
Yeah, exactly. Yeah. Get your caffeine at the ready. Yeah, I'm sure that there will be pros and cons, and always a period of adjustment, isn't there, with big changes like that. Steph, have you got a question for Ria and Becky?
Yeah, so first of all, thank you so much, Ria and Becky. I picked up a few things from there as well that I'll take back to my work, because I moved from the VTE prevention role. I'm now the medicines management matron. And one of the things that I realized when I assumed the role is that omissions, it's a very recurring theme, not just in VTE prevention, but in other medications as well. It's our number one theme for medication incidents until now. And actually, we're planning on a project sort of tackle omissions in general. So I picked a few things from your presentation. Fantastic work. So thank you for that. I wanted to ask about, so handover, so that's the interventions, the handover between the nurses. I wonder if you had feedback on the things that were picked up during the handover. As were the reasons that were identified for omission, did that change, or is it still the usual reasons of drug not available or blank reasons which were then picked up at handover? Is it just sort of similar reasons for omissions pre your intervention and during that handover?
Do you want me to answer that, Becky?
Yeah, go for it, Ria.
No, I think I'll bounce that back to you, Becky. No, I think actually that's very interesting, Steph, because what we didn't do was we just measured the fact that the effect on omissions. So I would then go in and audit every 2 weeks on the ward. So when we introduced the drug chart check, we then did just measure the number of omissions, and I guess we did see that we were still getting omissions with 4 or the blank. But what we didn't ask staff, and this would be useful to do, is when you do your handover, what do you pick up and why? So yeah, that's something that we could do, because we haven't completely cracked it. We're having to permanently nip at people's ankles over it.
So just slightly separate from the main Trustwide, when we're looking at the hats and we speak to the staff, when we're picking up the trends and looking at what's going on, we haven't really seen a change in the answers that they're giving us for why they've omitted. So we're definitely getting better at putting omission codes into the drug chart, which is great. So we've got a code rather than a blank. But then often when we go through the documentation, there isn't the documentation to support the omission. So when we then go and speak to the person who was doing that particular drug round and put the omission code in, the top answer quite obviously was, oh, I can't remember why that was omitted. And the second most common one, and this hasn't changed, is normally that either a colleague from the MDT team has asked them to hold it because they wanted to check something. So that could be the medical team were wanting to wait on a result of a diagnostic because they were concerned that there could potentially be some bleeding or something going on that would then be a contraindication for the prophylaxis. Or pharmacy have said, you know, we just want to check on this renal function because the renal function's been changing. I'm going to check this and come back to you. And then somewhere either the communication doesn't happen or no one gets back to the person. And then we were talking about this in the medication safety huddle yesterday, Ria, actually. It's really, really interesting because when you've got a really cohesive team that work together over a long period of time, you get that element of trust about each other's judgment. So then when we see a run of omission codes, particularly around the VTE prophylaxis, it's often a case of the guys are really busy on the ward and they will say, well, Irene, who I've worked with for 20 years, who would never omit a medication without a really good reason, omitted it yesterday, so there must be a good reason, so I'm going to omit it today. And then because everyone's so busy, there isn't that kind of going back and checking, well, actually, what was the reason for that? So that's what we've seen when we're looking at the cases of HATs.
Yeah,
that's really interesting.
Yeah, that's really interesting. And I
Mm.
think, yeah, that the check at the handover is something that I would reflect on and perhaps consider in our next QI project. So thank you for discussing that, and also the barriers that you have encountered as well. I can foresee some of our nurses saying that we don't have time for that. So, you know, we don't even have time for some of the things that we really need to do. But, you know, as you said, trialing it in a sort of few areas and see the impact and the improvement that would arise from that would definitely be a good driver for a sort of wider change. So yeah, thank you. Fantastic work. Congratulations.
Thank you.
Yeah, I echo that. Fantastic work, fantastic presentation. Thank you so much. We're going to move on now to hear from Steph. Stephanie Rivera is the matron in medicines management at Guy's and St Thomas's Hospital in London. And Steph graduated in the Philippines with a degree in adult nursing and worked in medicine initially before flying over to London to join us here at King's College Hospital. Such was the pull, she came all that way. Steph ran a nurse-led clinic to initiate and monitor patients on oral anticoagulants initially, and worked as a VTE prevention nurse here at King's College Hospital for some time. And in this role, she completed root cause analyses for hospital-associated thrombosis and just generally oversaw the Trustwide VTE prevention practice. In 2020, she was appointed as a matron for medicine management at Guy's and St Thomas's Hospital, and she now leads on the improvement and innovation in medicine safety throughout nursing practice across the hospital. So Steph is going to present her quality improvement case for low-molecular heparin omissions. Over to you, Steph.
Thank you so much, Emma. So just to mention again, this was a piece of work that I have completed a few years ago while I was at King's as the VTE prevention nurse, but we feel that it's still very much relevant today. So the things that we learned, the things that we found from this project. Next slide, please, Joe. So similar to Becky and Ria, in terms of the driver for this project, so as part of my role, I do the root cause analysis and investigation of hospital-associated thrombosis. And in 2017, we had this serious incident. So in NHS, we define a serious incident as an act or an omission in care that results in death or patient harm or serious patient harm. And there was this SI or serious incident when a patient with fluctuating capacity had 20 doses of low molecular weight heparin prophylaxis omitted during admission. And when we look at the reason for the omissions, it's due to patient refusal. And unfortunately, this patient died from a massive pulmonary embolism. So this incident really sort of made an impact on me and sort of prompted me to do something. It inspired me to sort of do a project that hopefully would lead to a change in practice. So initially with the help of our IT department, we collected an initial data, and we found that for every month, there were around 1,800 omissions of prophylaxis, low molecular weight heparin. Low molecular weight heparin omission. So this initial data was our sort of driver as well to start the project. We know that it's going to be a worthwhile project because we have this problem. Next slide, please, Joe. So what were the interventions that we did? So initially, my first intervention was around the delivery of teaching for nurses. I'm quite passionate about teaching. It's one of the things that I enjoy doing personally. So I amended the delivery of the teaching for our nurses during the clinical induction. So VTE prevention is part of the clinical induction for new nurses to the organization. So Previously, as part of the VTE teaching, I would tell the nurses, please don't omit low molecular weight heparin prophylaxis without the advice of the prescriber. Otherwise, it will lead to potential harm for your patient, PVT or a PE. And then I move on from there. But actually, in reality, based on my experiences as well as a bedside nurse, it's not as simple as that, really. You know, nurses face a lot of different situations, in addition to the pressures that they have thinking about when to omit to administer prescribed medication for their patients. So I thought when I deliver the VTE training, I'll include a few case scenarios to prompt thinking and reflection, and not just say don't omit and move on from there. So as you can see, the slide that I used in my teaching is on your screen, and it's just very brief, one line sort of situations that would sort of prompt discussion with the nurses. So for example, if your patient had a very low platelet count, or the patient just came back from a surgery, would you give the prescribed prophylaxis or not? So I think the key message that I drove during this teaching is, you know, to think about low molecular weight prophylaxis omission and its impact. And if you're not sure, then you get someone to sort of support you in making that decision. So it's sometimes, well, most of the time, it's not clear cut. So it's just prompting that reflection with the nurses as well, I found quite useful. Next slide, please, Joe. So we also added the missed doses on our electronic prescribing record VTE ward view. So at King's, where I used to work with Emma, we have a ward view, which is like an overview of patients in the ward. It has a list name of the patients and the different sort of domains of care. And one of it is VTE. So I linked with our IT department to request that we add a column so we can include the missed low molecular weight heparin doses. So as you can see there, there's one patient with 12 doses omitted of low molecular weight heparin since they were admitted. And the purpose of this is just on a glance, you can see which patients have been missing their doses. And this is something that we promote for different members of the MDT. So we do teachings for our consultant doctors, pharmacists, nurses. So everyone involved in the care, promote the use of the ward view and look at the dose omissions for low molecular weight heparin. So I usually sort of have a tagline before that VTE prevention is everyone's responsibility. So, you know, we can do our part to sort of protect our patients and give them the best chance of prophylaxis from VTE. So it's just this to highlight the doses omitted for the patients as part of our electronic support for our staff. Next slide, please, Joe. So we have our VTE newsletter as well, which I think we circulated every quarter. So it's just a summary of the updates for VTE prevention, some interesting incidents for hospital-associated thrombosis. And we also highlighted some of our clinical areas who are doing really well, sort of recognize them. So if it's a ward that's been doing really well in terms of their risk assessment, we sort of allocate a special section for them in this newsletter. So it's not mainly for omissions, but it's promoting best VTE prevention for our patients. And next slide, please, Joe. And then we have the audit for our link nurses as well. So I led the VTE Nurses Link Network at King's during my time there as the VTE prevention nurse. So I'm very much involved in the Medicines Link Network. I visit them in the wards and I chat with them, see what the challenges are, what the problems are, and sort of discuss how I can support them. And I give them extra trainings as well and feed it back to them. So if a hat happened in a different area, which they can learn from, I sort of feed it back to them to circulate the learning throughout throughout the trust. And one of the things that I asked them to do is a monthly audit. So it's a very short audit, usually takes them less than half an hour to complete. So I asked them to do a monthly audit, and we're lucky because it's available electronically, so they can just put it, input the data onto their computer. They don't have to print it out or scan it back to me. So there's a tool available from our intranet. They can use it to audit the care in their VTE. So I added a few questions about omissions. And obviously, as part of my training for my medicine-linked nurses, I tell them that if you find something that could potentially be a near miss or a potential for error, then we have the responsibility to at least flag that to the team so that something can be done for that patient. So I've got lots of feedback from my linked nurses that as part of their audit, they found omissions which are unexplained. So similar to what Becky and Ria were talking about in their presentation, unexplained omissions, and therefore they raised that to the team, and the prescriber and the nurse sorted that out, clarified the plan for that patient. So we thought that this sort of step has been useful as well. Next slide, please, Joe. And these are just some of the things that we regularly do anyway. So ad hoc teachings during safer care events or medicine safety week, for example, VTE week. I do random walk-in teachings for the ward nurses as well. And then we have dedicated VTE and anticoagulation study days, which we run regularly with the support of my colleagues in the anticoag team. And we have added a special sort of segment for low molecular weight heparin omissions as well. Next slide, please, Joe. And then obviously, as Ria mentioned earlier, it's important that we measure the impact of the project or the interventions that we did. So with the help of with the support of my consultant, Dr. Lara Roberts, we looked at the data, pre-interventions and post-interventions. And we have included the enoxaparin and dalteparin prophylaxis doses. So 20 milligram, 40 milligram for enoxaparin, and 2,500 and 5,000 units for dalteparin. So we have excluded the high dose prophylaxis for overweight patients. And we also have excluded the critical care patients because they use a different system, electronic system at the time. In addition to that, we also excluded omissions due to duplicate prescriptions, or if the patient has been discharged and if the nurses documented that they signed the paper chart, that's why they haven't signed the electronic chart. So we have excluded those. Next slide, please, Joe. So the data. So we looked at the total emissions, and we were very encouraged because we found a reduction, so from 13% down to 8%. So we looked at the total doses prescribed during a 3-month period, pre-interventions, and similar thing, we did that for 3 months after the interventions. We look at the doses prescribed and the proportion of omissions in comparison to the doses prescribed. So it's 13% to 8% reduction, which was quite good. Next slide, please. We also looked at the hospital-associated thrombosis due to inappropriate prophylaxis heparin omissions, and we found a reduction from 17% to 3%. Next slide, please, Joe. And then the reasons for heparin omissions. So as you can see, the number one reason we found pre and post interventions were still patient refusal. And then it's followed by clinical reasons for omissions. Next slide, please, Joe. So looking at the patient refusal, pre-interventions, it was 42% of all heparin omissions were because of patient refusal. did reduce a bit, but it's still a huge proportion in the post-intervention, which is 36%. Next slide, please. We also looked at the heparin emissions per ward. So you can see in most of the wards, there's been a great reduction in the emissions in comparison to pre-interventions. Apart from a few wards at the top, you could see, for example, Waddington Ward, Elfin Libra, for example, there's not a big or a huge reduction in prophylaxis emissions, but it's worth noting that at King's, these wards are hematology wards, so it can be because of the clinical condition of the patient. So for example, if they have very low platelets, then the heparin prophylaxis need to be omitted, and that's acceptable and the correct sort of management. So it's just worth noting that as well for this chart. Next slide, please. Okay, conclusions and recommendations. So further promotion of MDT approach toward the heparin emissions management. So yeah, it's involving everyone really, nurses, pharmacists, doctors into this UI project. And then we continue multifaceted interventions, including induction training for nurses with case scenarios, because we found that quite useful. Further promotion of the use of ward view to flag patients who had heparin emissions during admission. And in terms of recommendation, a re-audit to further monitor the trend in heparin emissions, and also, we recommended an audit, perhaps in a smaller scale, to look at the appropriateness of those emissions due to clinical reason, because this in my project, this involves thousands of doses. I don't have the resources to sort of look at those individually to see if it was a correct clinical reason, but it would be really interesting to see that on a smaller scale, just to look at the notes and see if the nurse selected clinical reason was that appropriate for that particular dose emission. And yeah, I think that ends my presentation. Thank you so much for listening. And if you have any questions, please let me know.
Steph, thanks so much for sharing that work with us. Excellent presentation. Really interesting, actually, that at King's, the primary reason for omission seemed to be around patient refusal, quite different to what you saw at Ashford and St Peter's. And I know that we've, in our nursing and midwifery network, we have had many discussions about how to tackle patient refusal, particularly when capacity might be an issue. I'm just aware of time. Unfortunately, we've been having such a good time. We've got so much to talk about. We are running out of time, but we have had a question from Susan that I'd like to put to all three of you, please. And she's asked, what was the most successful process for buy-in and engagement, as in who to approach first to disseminate your quality improvement project? We come to you first, please, Steph.
Yeah, in terms of who to approach first, I think senior leadership is very important. Presenting that data that you have initially to engage them. Because, you know, if you've got a senior consultant sort of influencing the whole team, I remember one time at King's, I had a call from a neurosurgical consultant asking me about ward view, and it felt really nice because they really have an impact onto the junior team, embedding it into their daily routine. So that's my sort of my first thinking. And the other thing is about being visible in the wards and talking to the challenges and pressures that nurses actually face every day. Because if they know that you're there to sort of, that you understand them, but you're supportive of them, I feel that they're more engaged to sort of get into your project and support it for patient safety. So I thought that's a useful thing to do as well.
Great, thank you. Becky and Ria, maybe for the interest of time, one or the other of you answer this question?
Do you want me to take it, Ria? I don't mind. We'll probably have slightly different answers because we had different involvement. But for me, in terms of what was really important for getting the engagement, I'll speak to that bit because Stephanie answered about who to approach. It was you know, contextualizing the data was really, really, really important. So as you touched on earlier, Emma, it's about people understanding the effects of what's going to happen, humanizing it, what's going to happen potentially to these people, what has happened to people in our care, but also contextualizing, again, touching on something that Steph just said there, what's actually happening within the care environment where the care is being delivered that is helping to stop these things from happening or contributing them to happening. So it's all about contextualizing it, because then the engagement follows, because people have the understanding and they want to improve things.